mortalidad materna. Voy a comenzar poniendo un pequeño mensaje acerca de cómo manejar la interpretación. Welcome, colleagues. This is a message special for English-speaking persons. You have below in the bar an icon with the word. Please press there to open the translation in the language that you prefer. Colegas, vamos a hablar en la mayoría de la reunión en español, pero también si ustedes precisaran traducción en algún momento, yendo al icono que dice interpretación.
Most of us will be speaking Spanish, but if you wish to select interpretation, you can keep Spanish and you can select the language of your choice. So for me, as the coordinator of the Secretariat of the Regional Working Group, it is a real pleasure to welcome you all, and particularly on behalf of my colleagues and the agencies that they represent. Today, we have planned to organize this webinar focusing on two objectives. The first objective is to learn the current status of the recommendations on immunization for pregnant women. And the second one, and not less important, is that selected countries that have had a special impact with vaccination of pregnant women can tell us about their experience so that this can be extrapolated to other scenarios. At this moment, I will be introducing a colleague, so Alba Maria Ropero Alvarez, so she can tell us about the state of the art. Alba Maria is a regional advisor on immunization of the Department of Family, Gender and Life Cycle of PAHO and the World Health Organization. She has more than 20 years of experience in public health. She was a head of programs of infectious diseases and deputy director of communicable diseases of Colombia's Ministry of Health before she joined PAHO. As a regional advisor on immunization in the Americas, Alba Maria leads the efforts in immunization against influenza, hepatitis, yellow fever, as well as other infections. She has also played a relevant role regarding immunization of pregnant women during this period of pandemic. That is why we have invited Alba Maria today, so that she can share with us the current status of immunization in pregnant women. Alba Maria, thank you for joining us today. You have the floor. Good morning. Thank you for your invitation and for the introduction. If you allow me, I will share my screen now. Please let me know if you can view my screen. Yes, we can. Perfect. Yes. All right, thank you very much. For the purpose of this presentation, I will be making a brief outline, which is as follows: the background, the epidemiological situation, the recommendations for pregnant women, and the status of vaccination. Let me start with this information regarding the maternal immunization platform, where COVID-19 joins this platform in response to the pandemic. And of course, as you are all aware, as evidence and the pandemic evolve, these recommendations are then adjusted. And this is important because, as we are aware, pregnant women are excluded from research. This has led to the fact that there is a gap in the lack of evidence, which has affected the recommendations regarding the recommendations for pregnant women, as well as the discussions with Ebola. And there was a major discussion regarding the inclusion of women pregnant women in the clinical trials, particularly in the advanced phases, for example, in phase 3 as well as in phase 4. We need to generate more evidence so that we can close this gap regarding access to vaccination of pregnant women. In this slide, we can see the different vaccines available. We have 326 candidate vaccines, from which 132 are in clinical development and 194 are in preclinical development. From these, we have 7 vaccines that have been approved for emergency use by WHO, and these are the teams that produce these vaccines. These are sites of production. All these have to be authorized by the WHO. And SAGE is a technical advisory group on immunization of WHO for recommendations of vaccines. They update, review and update these vaccines that have been approved for emergency use. They make their recommendations based on evidence. And based on the new evidence, they make an update on a permanent basis. The latest vaccine adopted for emergency use was the Marad vaccine from India, which is inactivated virus. As regards the epidemiological situation, we have the number of maternal deaths related to COVID-19 in the region of the Americas. More than 325,000 confirmed cases of pregnant women positive and more than 3,200 deaths from COVID as at October 2021. This slide shows the information of some selected countries regarding the proportion of pregnant women who required hospitalization and particularly intensive care. We have Chile, we have Mexico, and the United States. And on the right, we have the comorbidities reported in pregnant women, the most frequent ones. Here we have Mexico and Chile, where we see that obesity, diabetes, hypertension are the main causes of comorbidity in pregnant women. There is a lot of evidence regarding the higher risk of pregnant women of having COVID-19 with increased use of ICUs compared to other women who are not pregnant. We also are aware of the higher risk of preterm birth or having infants in the ICU. Also well known is the risk of women aged 35 or older who are overweight or who have pre-existing medical conditions. They are at a higher risk of developing severe COVID-19. This information here is a recent publication on maternal death in Mississippi. And the interesting thing here is that before the prevalence of the Delta variants, the predominance of the Delta variants, we see an increase in mortality. And I would like to say that the existing vaccines have a high effectiveness to prevent severe disease and death. Now let us see the recommendations of the SAGE and the TAG. The WHO made a roadmap for recommending priority use of COVID-19 vaccines in some age groups. One has to do with the health workers who are at a high to very high risk of acquiring this infection, and this also included pregnant women. These entered as pregnant women entered as this group. So for the purpose of this recommendation, this was not only the epidemiological situation, but also the availability of vaccines. So the purpose of the first stage, where it was expected to have a proportion vaccines of 1 to 10%, then priority was given to the health workers and to other adults with specific risks. And pregnant women were included in stage 3. Now, this changed over time as evidence started to become available. So the WHO updated the recommendations in July 2021. The important thing to show here is that it went from stage 3 to stage 2, namely that pregnant women were included as high-risk group, and the evidence, it was determined that they were at a significantly higher risk. So here we now have the different types of vaccines that are recommended, and the SAGE revises each of these vaccines and the evidence that starts becoming available. That's why the recommendations become updated. Recently, they reviewed the Pfizer and the Moderna vaccines, and they updated where they emphasize the importance of using this in pregnant women. There was also a language where they stated that vaccination is recommended only if the benefit of vaccination to the pregnant woman outweigh the potential risk. But we know that the risk of infection is potentially higher than the risk of vaccine. The advisory group in July reviewed the recommendations and also recommended vaccinating all pregnant women. And this is the same information on the vaccines with the approval for emergency use, and we now added information regarding the safety of these vaccines. All the vaccines have been studied in animals where no harmful events were detected in animals and their offspring. And then regarding the safety for AstraZeneca and Janssen, no higher risk was associated to thrombosis and thrombocytopenia. Inactivated vaccines, in this case, we have had two so far. As we are aware, inactivated vaccines have been highly used, and also with adjuvants, which are well known for vaccination in women. The latest one from India, which was approved in November, this month of November, uses a new adjuvant. That is why it is important to monitor potential events regarding the use of women. 1 to 20,000 pregnant women have been vaccinated in India, and no issues have been reported so far. Regarding implementation, globally, more than 7 billion vaccines have been applied. In the Americas, 51 out of 51 countries and territories have introduced COVID-19 vaccines. The origin and access to the vaccines has been through bilateral agreements or through the COVAX mechanisms, as well as local production or donations. About 1.3 million doses have been administered in the region. Here we have the countries that have applied more vaccines per 100 inhabitants. We have Chile, Cuba, Uruguay, Canada, and Panama. In Latin America, 51% of the population has received 2 doses, so the complete scheme.
But this global information doesn't show inequalities in the region, and my intention is to show these inequalities in the region where close to 19 countries haven't reached 40% of the population with 2 doses. We have Nicaragua and Haiti below 10, and of course countries that have worked very well and vaccinated the most important part of the population, but 32% above 40%. WHO established this goal to reach at least 40% by December and 70% by June next year. We have over 15 vaccines used in the region. The most commonly used are Pfizer. Here we have the different countries using this and the different vaccines. in the Americas. As for vaccination policies, we have the SAGE recommendations, the TAG, and support from the advisory technical groups in the countries, and also gyneco-obstetrics societies, and FLOTSOC, for example, in FIGO, where they recommend vaccinating pregnant women. Countries have introduced vaccination in different manners with the advance of the evidence. Some countries only recommended high-risk groups and then have progressed towards universal vaccination. They have also extended the recommendations some had for the second or third trimester, now in any stage of pregnancy. But it's one thing to have the recommendation and another thing to apply the vaccine. That is what is important right now. And that is something we're urging our audience now, the importance of vaccinating pregnant women with a complete or full vaccination scheme to prevent the infection and particularly of any sort of variant. Here we observe, here we have the report to PAHO, sorry, not all countries are reporting, but there are low vaccination rates in the US. We see close to 34% of women vaccinated, but in the Americas, we need to increase the rate as soon as possible with the full scheme. What has happened in the region regarding monitoring adverse events? That is essential in the use of the vaccine and its acceptance. We must demonstrate through adverse event monitoring systems that vaccination is safe. And PAHO has worked together with the countries to develop a surveillance network, both passive and active surveillance. We have 34 hospitals at regional level with active surveillance, 4 of which are maternal hospitals, maternities. We have seen global work to develop handbooks and training, so implementation of surveillance of adverse events, and we have a handbook for surveillance in pregnant women in particular. This is a one developed for the Americas or tailored for the Americas. It's important, therefore, to demonstrate that vaccines work. Here, I show the surveillance systems in the US, the VSA, that's an active surveillance system that has conducted many studies and hasn't found issues with safety of vaccines. And if we compare it with a baseline of abortions and other outcomes, we don't see signals of concern. However, it's important to continue monitoring this very closely in order to convey this sort of message and have better acceptance of vaccines in pregnant women. To conclude, I would like to highlight that the evidence suggests that pregnant women with COVID-19 are at a higher risk of developing severe disease and requiring intensive care and mortality. SAGE and TAC recommend that all pregnant breastfeeding women receive the COVID-19 vaccines. It is critical to increase vaccination coverage in pregnant women. That is our real message, because there is very low coverage. As for the importance of informing women about the risk of infection and mortality, and also the benefits of vaccination, and that there are limitations of safety data, but that there are many ongoing studies that increasingly reassure us about its safety. It's important to identify the reasons for non-vaccination or vaccination hesitancy. As stated, preliminary findings do not show obvious safety signals among pregnant persons who received the messenger RNA COVID vaccine or the AstraZeneca and Johnson vaccines. stage is always recommending that if you're going to use a vaccine for pregnant women, that we look through the position papers and recommendations made in relation to them, because they are constantly being updated. So this is the end of my short presentation. Thank you very much for your attention. This is the work team for maternal immunization. Thank you. Thank you, Alba Maria. I wanted to make some comments regarding your presentation. First, to thank you, but you stuck to the time allocated. All the colleagues present will observe that in the bar, they have this place that says questions and answers. If you have any questions, particularly for Dr. Alba Maria, please write it down there and we will convey it to her. I wanted to highlight some things about your presentation. First, one of the topics mentioned is very essential and regards what you mentioned about the importance of having this recommendation of vaccinating pregnant women. But what's important is the application of this. Indeed, most countries in the Americas have, as you showed, this recommendation ruling with differences. However, in many, the vaccination levels of the whole population are below 40%, meaning that pregnant women are far from being contemplated in those vaccination schemes. In turn, when you show the list, there are only 8 countries with 70% coverage with 2 doses, meaning that the vaccination levels of pregnant women might be a bit higher. But now, specifically regarding something you mentioned, and that I hadn't seen until then, regards recent recommendations from SAFE. Could you please clarify why, in relation to the messenger RNA vaccines, they're saying they're promoting the use, while the others, AstraZeneca and the recently approved from India, they're saying the same thing they have been saying for a long time, that you have to balance the risk and benefits. Do you know why this is so? Well, thank you for your comments and the question. First, I would like to highlight the first issue about the importance of implementing policies. It isn't only having this recommendation, you have to vaccinate and reach these women. Not only pregnant women, must protect the pregnant woman and the family living with her, because we know about the high risk for becoming ill and dying. So the call is for countries to generate, to implement mechanisms to improve vaccination coverage. There are bonuses. The countries have different mechanisms established, allowing them to improve and encourage vaccination. So it's very important to have those mechanisms and reduce the reasons, or identifying the reasons for non-vaccination. Could be doubts, lack of information, so we ought to provide appropriate information to mothers and families when possible. As for the recommendations, this evidence is updated, and that's why I said that each of these vaccines is reviewed according to the evidence that arises, and that has been advanced in the language. We at first questioned before our TAC meeting that the language was a bit restrictive for recommendations when we have very high mortalities. That's why our TAC recommended vaccination to all pregnant women due to the high risk. SAGE only modifies recommendations with new evidence. So there have been many safety studies published with messenger RNA vaccines, both Pfizer and Moderna. That's why it was updated, and not with the others. And this new vaccine, Bharat from India, the interesting thing of keeping that language is because there's this new adjuvant that hadn't been used before. As against Sinovac and Sinopharm that had the traditional adjuvants we were familiar with during long years after vaccinating pregnant women where it has been demonstrated there's no risk. In this case, we need further follow-up studies for safety, and that's why we have this adverse events detection platform. So the language changes with greater evidence, but in principle, with the update in July 2016, without touching these different recommendations, they passed pregnant women to a high priority risk group, recommending their pregnancy. So the recommendation here is the risk of the virus according to the transmission in the community. If there's transmission, you must vaccinate pregnant women with whatever is available. Good. I also wish to highlight that the PAHO position has been much more progressive as compared to SAGE with this recommendation mentioned in July. I will take 4 questions and no more from the chat in order to go on to the next speaker. I will tell you the questions and you may, well, I give them both. First by Walter Mendoza, and he says how to face the myths circulating among pregnant women that make them hesitant to vaccinate. And then from Jose Malaga that says, what is your view regarding cases reported of young women with cardiac morbidity due to messenger RNA vaccines? Thank you. How to manage myths? Here, we need an educational process, and the health staff plays a significant role in the message conveyed regarding the importance and safety of vaccines, because it's people who are closer to the recommendation, and thus the acceptance of this recommendation. We must also generate educational and training mechanisms in the media. Social networks are misinforming about safety and the importance of vaccination, so we need educational and training strategies to reach them through the different social networks and media, but also identify these myths. So based on them, at local level, we must be familiar with a cultural level, at municipal level, to design educational measures capable of reaching these populations. We must generate different strategies to overcome myths, but we know there's this great invasion of misinformation through the social network. So education, 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 training, information, and the role of the health staff to recommend vaccination, because we know that often they are not recommending vaccination. Thus, its importance. As for Jose's question in relation to adverse events and heart disease, some events have been reported in young people vaccinated with the Johnson & Johnson vaccine that have had a favorable course. This is among the reported events. It's being studied, but doesn't generate a risk in relation. This is part of the surveillance of the different vaccines, and thus we know that if we don't have sensitive surveillance systems, we won't be able to check the events and tell what are the recommendations according to the availability and so on. So it's well known, and WHO analyzed it and made communication in this regard, stating that the benefit of the vaccine is much higher than the risk.
Son las dos preguntas que tenemos. El resto de preguntas que están apareciendo.
Thank you, Alba Maria. I will ask the questions that have come up, and the others we might be answering as we go along with the session. Olga Araya is asking regarding the dates of the data you showed us. Are these recent? These have been included in the slides, Olga. So there even is a colleague in the other chat that is asking access to the documents. Once you view the recording, you can access the links included at the bottom of each of the slides showed by Alba Maria. So the next question is from Araceli Cepeda. Is there any restriction regarding vaccination depending on the gestational stage of the women? There is no restriction. Vaccination is for all pregnant women, even adolescent mothers, and Pfizer and Moderna have been recommended for adolescent women. The important thing is to vaccinate pregnant women as soon as possible regarding of the age. Of course, women aged over 35 have a high risk demonstrated by the international interest evidence. Adding on to the stage of the pregnancy, is this allowed for any stage? But most of the regulating entities recommend vaccination after week 12 in order to overcome that date in which most of the spontaneous abortions take place. I'm sorry, I confused the pregnant woman's age and not the stage of the pregnancy. Thank you for clarifying. Thank you very, very much for your contribution, Alba Maria. I think this topic, although the how many months we have had of pandemic, this has been most interesting. But the arrival of the Omicron variant would also pose a challenge on the effectiveness of the vaccines. So we'll have to continue talking about this topic. If you allow me, and just give me a second regarding Omicron variant. Let me highlight something here that is important regarding the variants and also regarding vaccines. Vaccines are highly effective for severe diseases and to prevent hospitalizations and death. All the vaccines have demonstrated their effectiveness, including for the variants that we have had to face. We have already faced variants in the past, and we'll continue facing variants until we don't reach high vaccination rates among the population. So let us not panic and continue working with the strategies that we have, namely vaccinating the risk groups and also applying the public health measures, namely social distancing, the use of masks, and vaccination. So we have to see this as a set of public health interventions. It is still too early to determine how this new variant will evolve, but we now do have the tools that we can use, such as vaccination and the other measures. The faster we vaccinate, the faster we will decrease the risk. Thank you very much, Alba Maria, for your contribution. So now I will introduce my colleague in the GTR, who is known by almost all of you, Alma Virginia Camacho. Alma Virginia is a regional advisor on sexual health and reproduction for the Americas region. So now you have the floor for the next module. You will have the opportunity of listening to real experiences of countries from the region that have been dealing with this. You have the floor, Vicky. Thank you, Bremen. I will start then my panel. First of all, I'd like to introduce our colleagues who will be participating in this panel, Paulino Vigil, Claudio Sosa, and Patricia Beiluga. I would like them to turn on their cameras. Patricia, Dr. Beiluga, are you there? Hi, Vicky. Good morning, everyone. How are you? Good morning. So there we have the presentation of the three colleagues. I will just briefly read these. First of all, I'd like to introduce Mr. Claudio Sosa, who is a professor of Gyn-Ob at the University of the Republic of Uruguay. He has a master's degree in public health from the University of North Carolina in Chapel Hill and has a doctor's degree from the Public Health School in Medicine and Tropical Disease in New Orleans. He's president of the Gyn-Ob Society of Uruguay and a member and honorary advisor for the President's Office on topics related to the COVID-19 pandemic. He's also a consultant of the CLAP. Paulino Vigil de Gracia is a gynecologist and obstetrician, specialist in maternal and fetal health, researcher of the National Research Group of the CENACIT in Panama. He's a scientific director of the Latin American Federation of Gyn-Ob. He's a president of the Panamanian Gyn-Ob Association, member of the American Gyn-Ob Association, member of the School of the Medical Academy of Panama. He has authored many publications and books and book chapters, has conducted clinical research. We have Patricia Veiluva, who is also a Gyn-Ob. He is a Director General of the programs of the Ministry of Health of Paraguay. So now I would like to give the floor to Dr. Claudio Sosa, and the dynamics will be with questions and answers. There will be no presentations, but we are especially interested in learning about your experience regarding this working modality. So for Dr. Claudio Sosa from Uruguay, we hope that we'll give you 4 to 5 minutes to answer each of the questions. The first question for Claudio Sosa is the following: which was the scientific basis with which Uruguay decided to recommend vaccinating against COVID-19 to pregnant women, and which were the national scientific groups that participated in this decision-making process? Claudio, thank you for your presentation. To speak about vaccination in Uruguay, evidently, this was a result of all the analysis conducted when the pandemic began in Uruguay. Uruguay specifically, I see we have people from all over the world connected. Uruguay is a small South American country. On March the 13th, 2020, the pandemic began in our country. And one of the things that was done initially was that the executive, the president's office on April 16th, 1 month later, decided to set up a group of scientists. And this was done through a well-known Uruguayan scientist, Rafael Radi. He was the link with all the scientific people at the universities. We have public and private universities. So at the time, we're not speaking about vaccines. We're speaking about what was going to happen regarding the uncertainty. We had experts in mathematics, experts in statistics who were constantly monitoring the outlook for Uruguay regarding the entry of the different variants and events, and also the response of the health system, namely to determine the need for intensive care capacity and so on. So they developed mathematical models that allowed to see things that showed what was about to happen. And the other group was made up of 55 scientists. Half was dedicated to data and others were people from the health area. And I started with Gyn-Ob to think about telemedicine regarding prenatal control. We're not speaking about vaccines at that stage. And we also had different areas of the medical field. Now, regarding vaccines in Uruguay in 2020, the pandemic was the situation in Uruguay was controlled quite well prior to the vaccines. Towards the end of 2020, some events started to make things more complicated. We had the first wave. There were no vaccines available, yet we knew that these were being developed. The second peak was then in March, April this year, the first maternal death. We had 10 overall. 9, in fact. One was a positive COVID with an adverse event. So these were back in March, April, and May this year. So this scientific committee of the Ministry of Public Health had a strong influence. There was also a committee on vaccines And pregnant women had not been included initially in the groups that were to be vaccinated. So towards the 8th of March, the scientific group, and in view of the reports published by the American in North America and the status of vaccination, we decided to start working. The first recommendation was made by the scientific group. The Ministry of Public Health did not adopt this recommendation of this group of scientists right away. We started to recommend vaccines for patients at risk. These were those patients that had comorbidities, like Alba Maria mentioned, particularly obesity, diabetes, and hypertension. And of course, there were many obstetricians and who are also exposed to this. So the scientific association started to make recommendations. This was back on the 8th of March. 1 month later, a second recommendation was made that was open to all pregnant women, because in the meantime, we had 2 to 3 maternal deaths. In Uruguay, a maternal death is right away published in the media, and even pregnant women started to become worried about this. But basically, the good thing about Uruguay is that the groups of scientists were directly involved with the decision making. Of course, the last word was in the hands of the executive, of the president, but they received all the input, and meetings were held on a regular basis, and these recommendations issued by the group of scientists were then adopted or not by the Ministry of Public Health. Thank you, Claudia. That was interesting. I'd like to ask Paulino Vigil from Panama to share with us the experience in Panama and the scientific basis on which the recommendations for COVID-19 was made to include pregnant women, and also what was the participation of the groups of scientists in this decision-making process. Paulino, you have the floor. Thank you very much, and thank you for giving us the opportunity of sharing this with you. There are many justifications that were used. One had to do with the type of vaccine. This was a vaccine that was not inactivated virus. This is a totally new type of vaccine. And if we were to analyze this with mRNA, from the standpoint of many researchers, there was no scientific reason that would make us decide against the use of this vaccine. And we started vaccinating in January this year. So the type of vaccine was what led us and many groups to advocate for the application of these vaccines. This began in January the 20th for the population at risk. So in the United States, this was already being applied to pregnant women.
In Israel, there were case reports, so we started scientific pressure. The Obstetrics and Gynecology Society was an ally. On the one hand, we thought this was a vaccine where, although there wasn't evidence of benefits in pregnant women, due to the type of vaccine, it didn't signify a risk to mothers and babies. But there was a report from the CDC in October, November last year that was very important about the high risk of ICU care, mechanical ventilation, and death in pregnant women. So this important risk with the infection of COVID-19, the type of vaccine and the experience we had had in Panama, we started the year before in 2020 to gather information of COVID-19 in the first 6 months. This has been published, and Apparently, these data are identical to those reported by CDC from March to October 2020. 50% of the pregnant women dying in Panama had COVID-19. So this justified the strategy. Similarly, the mortality reported by the CDC that supported this and the type of vaccines that would reach Panama made this necessary. So there was pressure from the Gynecology and Obstetric Society that this had to occur. And what happened, similar to other countries, the very high-risk population was first vaccinated. There we had health personnel, where there are pregnant women. So we passed from the academic discussion together with the Ministry of Health, and fortunately they called the Gynecology and Obstetric Society a month later, and we participated and we reached a decision on the 2nd March this year to start massive vaccination in pregnant women. Those were then basically the reasons why we decided to administer this vaccine against COVID-19 in pregnant women. Opinion leaders, the Society of Gynecology and Obstetrics, the Ministry of Health. So we started vaccination very early on, since the vaccine was available in the country. Thank you, Dr. Paulino. Now we're going to ask the same to Dr. Beluga to contextualize the situation in Paraguay, the scientific basis for vaccinating pregnant women against COVID-19, and if the scientific societies participated in the decision-making process. Hello, good afternoon, everybody. Indeed, all the scientific bases published from the American College, from FIGO, from PASOC, and also scientific societies, the Paraguay Gynecological and Obstetric Society and Society of Obstetricians from Paraguay, all participated and conducted a very good campaign within the health ministry to include pregnant women among the priority groups. Although there was a delay in starting vaccination to pregnant women, the evidence, the epidemiological evidence showed a significant number of maternal deaths. By April, May, we had 76 maternal deaths, of which 62% were due to COVID-19. All these reasons contributed to include pregnant women as a priority group. But we had a great difficulty, and that was availability of vaccines, appropriate vaccines for pregnant women. And until now, the first to reach was Moderna, that was used at worldwide level and supported by WHO for pregnant women. So those bases were used, the sort of vaccine, the scientific evidence that was arising at global level, the neighboring countries such as Chile, Argentina, and Uruguay that already started in April and May to vaccinate their pregnant women, and the scientific societies had provided significant support at the National Technical Committee for Vaccination, supporting the immunization program from the health ministry. So in the first weeks of June, vaccination for pregnant women was included, but after a significant number of pregnant deaths, unfortunately. There was a strong wave in Paraguay at the time, and this led to the death of many pregnant women. Thank you, Dr. Veilua. I think we have a good overview of the discussions within the countries and the significant contribution of scientific societies within the countries, but also with some support from the evidence at international level and the political decision that directly impacted the onset of vaccination for pregnant women in countries early on and a bit later in Paraguay. But as explained by Dr. Beluga, at the time, they didn't have the recommendation for the vaccines they had. So they decided to wait to have it for the context, because I repeat that now we have other vaccines approved for pregnant women. Well, after this introduction, with this interesting analysis of the decision-making process in terms of policies and programs for pregnant women, I want to ask Dr. Paulino, what is the coverage of vaccination to pregnant women in Panama today? We know there's been an excess of maternal deaths during the COVID-19 pandemic, and therefore, if you could add on about the effect of vaccination in maternal mortality. Yes, very interesting question. Let us consider the figures to better understand. Panama has 4.3 million inhabitants. We have close to 70,000, 75,000 births per year. Last year, in Panama, by mid-March, the pandemic started and pregnant women began to die. When we closed the year, we had this first wave in June, July, and the second one that started in November, December, January. 50% of maternal deaths were due to COVID-19, not linked with. Some died with COVID, but due to other complications, so that's a difference. But if we gather all this, we see that there are 11 maternal deaths due to COVID-19. Probably the figures are scarce for some countries, but I mentioned the number of births per year. But for us, that was 50% of COVID-19 associated deaths. So it was very impressive. So we started to vaccinate in the country. They supported my opinion leaders and scientists and the society, and the ministry accepted all this. So what has happened following vaccination in Panama? Surprising. We had a high risk. I work in a high risk unit, and last year, August, September, October, November, every day I saw at least 5 COVID-19 pregnant women in a complicated situation. After starting vaccination on the 2nd March, I may say that I rarely see COVID-19 complicated patients, one every 1-2 months. This clearly states the impact of the vaccine. But how many people have been vaccinated? This is interesting, including pregnant women. Close to 60,000 pregnant women vaccinated. What is the percentage? And that is very important. So we're estimating based on the number of pregnant women we had last year. We don't know how many we have now. With close to 70% of the pregnant population vaccinated with 2 doses, but also vaccinating postpartum women. This that is happening with pregnant women has a parallel with what we see in hospital. Since March, we haven't had a maternal death due to COVID-19 in the country, and have only 2 patients in intensive care, ventilated and both not vaccinated. We've also observed in the past months that the acceptance of vaccination by pregnant women is high, increasingly so. So in spite of the anti-vax groups we have in Panama, they're not so strong, and they don't really impact on pregnant women's vaccinations, fortunately. So the experience is extremely good. And I repeat, we only use a Pfizer-BioNTech vaccine. Thank you. Very good news for everybody, and particularly for us working in public and perinatal and maternal death. Claudio, the same question for you in Uruguay. What coverage have you had to date with COVID-19 in pregnant women? And You also mentioned it at first, that has been an excess of maternal deaths due to COVID-19 in the country. What has the effect of the vaccine been on maternal mortality? Well, quite similar to what Dr. Virgilio de Gracia mentioned. Very similar behavior between April, he corrects himself, March, April, May. They had 9 deaths due to COVID. So there was a doubling of the figures. We have 6,000 deaths per year. There has been a decrease, and that was important to promote vaccination and extend it to all women, not only pregnant women at risk. And when the ministry in April made the recommendation and included some recommendations, and will later refer to logistics to have easy access, we considered we had 22,000 pregnant women with prenatal controls. Surely there were more, and the goal was to reach them all. And in less than a month, 18,000 had been vaccinated. They were included in other vaccination systems, but it was very fast in Uruguay. So we nearly have 77% with 1 dose, 74% with 2, and 40% of 3 doses. And this because we saw a very drastic change. We didn't have more maternal deaths, and admission to the ICU, I think we haven't had any in the past months. And of course, a great change beyond pregnancy, because at present in Uruguay, well, we don't want a new variant, of course, but we feel quite comfortable. Of course, we're concerned about what's happening elsewhere, but this associated to success of vaccination that was very intense, and at present, it's very easy to access vaccinations.
Hablamos un poco cómo fue la agenda electrónica y se accede fácilmente.
It's quite easy, and there isn't this possibility of somebody not being able to have a vaccine in the short term. The deaths were focused in 1 month, 1.5, and that really was very striking. And there were changes even in pregnant women who asked, where can I have the vaccine? Where some people said, beware, we don't want to vaccinate pregnant women. So there was a poor communication starting in the paper recommendation and in the sites proper. But this has improved, and I think we're about to succeed. We hope nothing new arises with the new variants. Thank you, Dr. Sosa. Another good practice and good outcomes, because in the past months, we've seen 0 maternal deaths due to COVID in Uruguay and Panama. So this seems to be a very striking outcome, not only in these 2 countries, because vaccines do work. And now for Dr. Beizluga, we know that Paraguay has implemented a special strategy to vaccinate pregnant women together with an important vaccination campaign called DDE. Could you describe the outcomes of this campaign, this communication campaign? What coverage have you obtained to date, and if you observed an impact on maternal mortality?
Bueno, realmente la campaña fue interesante, tuvo un gran impacto.
Well, the campaign was very interesting. It had a strong impact in terms of communication. We call it Day E, and it was dedicated only to vaccinating pregnant women. We saw this as a strategy because we had a large number of maternal deaths. It is true that at that time, we had key indications to be able to access vaccination, namely women aged over 18 who were in week 20 or more of their pregnancy. So this was the minimum pregnancy stage, although the scientific associations has stated that after week 12 they could access vaccination. The extended immunization program determined that at least they had to be in week 20 of their pregnancy. So we had about 17,000 pregnant women who had registered to receive the vaccination, and on that vaccination day for pregnant women, about 4,000 pregnant women were vaccinated. So far, we have a coverage, and the number of births is between 100 and 5,000 births every year. So we have a coverage of about 30% in pregnant women with the first dose, and about 20% have received the second dose. And so far, this has not been, the third dose has not been authorized, because one of the main problems we had in the country was the availability of the different platforms, and those indicated for pregnant women. So the impact of the campaign was very big. In June, a large number of pregnant women were vaccinated, and maternal deaths were reduced to zero practically as a result of COVID. But in the past 3 weeks, we have once again received reports of 4 maternal deaths from COVID, but these pregnant women had not been vaccinated. At now present, we're doing extreme monitoring, and some are hospitalized with mechanical ventilation, patients with COVID, but these have not been vaccinated, particularly people who are anti-vaccine, people from the borders with Brazil, where this standpoint is very intensive. So these are the ones that are in more difficult situation. What measures are you taking to increase the coverage of vaccination in pregnant women in Paraguay? Well, we have now decreased the pregnancy stage to week 12. We have also included adolescent pregnant women. They receive the Pfizer vaccine, which is now available, and the communications campaign, which is something that promotes the access of pregnant women to vaccine and to try to eliminate the fears they have of being vaccinated. And this is for these pregnant women who fear this, the vaccine. Are they in the capital city? Are these from the indigenous communities? Or are in the border areas? Yes, most of the pregnant women who don't wish to be vaccinated are from the border with Brazil and also from the rural communities. In the capital city and the larger area of Asuncion, which is a capital city, most of these women have been vaccinated. The vaccines are available, the vaccination posts are all available. The campaign is quite clear. The Ministry of Public Health encourages women to go to the vaccination posts to be vaccinated. And now we have implemented the option of going from door to door to vaccinate these pregnant women to try to eliminate the fear they have of being vaccinated. So what would be the challenges you have from this way you analyze this from the government? What leads pregnant women not to receive the vaccination beyond the anti-vaccine movements along the border with Brazil? Because if you do have enough vaccines, there are vaccination posts, you communicate and inform the population. Well, going from door to door, this strategy will also increase the number of vaccinated women, and also the possibility of accessing the vaccination posts because of means of transport. So it was then decided to implement this new option. We started 15 days ago, and hopefully this will work, because this is an important challenge, a real challenge that we are facing, namely trying to access all the pregnant women. So this is going from door to door. Thank you, Patricia. And thank you very much, Dr. Beiluga, for sharing with us the situation you're facing in Paraguay. This is similar to the situation that other countries also face, other countries from the region, regarding the challenges, regarding the anti-vaccine movements, which in some countries are more intensive than in others. And also based on this ongoing analysis you carried out, you have managed to identify the main strategies that are effective. So hopefully this strategy of going from door to door where pregnant women live will contribute to increasing the number of vaccinated pregnant women. I'd like to ask Dr. Paulino regarding, I will start closing, I will focus on some questions, but we started a bit later and we took longer with the initial part of the webinar. But I think, well, some questions have been answered already, but are you offering a booster to the vaccinated women in Panama? Well, yes, some days ago, and also following the instruction of the President's office, all the population aged 18 and more will receive the third dose if 6 months have elapsed since the second dose. And this includes pregnant women. And I say this because about a month and a half ago, this was only for the population aged over 55 or population with health risks. This did include pregnant women, but now, since last week, the third dose has been recommended if 6 months have elapsed since the second dose. In Panama, we have Pfizer-BioNTech. In Panama, they were vaccinating the young population with AstraZeneca. Some pregnant women have this 2 doses of AstraZeneca, and we're now recommended to be we're recommending pregnant women who receive the 2 AstraZeneca doses to receive the Pfizer vaccine as a booster dose. So you're also offering, Dr. Sosa, are you offering the third dose, the booster dose to pregnant women? Yes, we're offering this to the general population. The agenda was first for the elderly, so initially the elderly were those who received first the third dose, the booster dose. This has now been extended to all the population. We have an electronic agenda through which you can register for being vaccinated. The Ministry of Public Health has a register with the identity card number of each inhabitant. The system, the Ministry of Public Health, then checks the identity card number to verify whether this is a pregnant woman, who are then prioritized in the agenda. So very rapidly, pregnant women can state that they are pregnant because they wish to be vaccinated. So somehow this has been well implemented, and we have many pregnant women who have received the booster dose if they were vaccinated 6 months ago. In Panama, they are vaccinating pregnant women with BioNTech because it's the vaccine that is mostly available in the country. What about Uruguay? What are the vaccines that you have available for pregnant women? How did you make that decision? Well, initially we had CoronaVac from Sinovac. This was for the entire population, and BioNTech, and also AstraZeneca. And AstraZeneca, because of the publicity regarding thrombosis, etc., people registered and they told them that there was AstraZeneca, and they said, well, I don't want to have that vaccine. And then they once again registered for being vaccinated. That is why AstraZeneca was not very successful. For that reason, the Association of Gynecologists decided to recommend Pfizer-BioNTech. CoronaVac Sinovac is a very well-known platform, but there's not too much direct current information. But nevertheless, a lot of information was produced from Pfizer, basic studies, and now some randomized studies, whereby the ministry decided to offer only Pfizer to pregnant women. So in other words, we had CoronaVac Sinovac for pregnant women, then with Pfizer, and now exclusively pregnant women receive Pfizer. The young people and children are also being, when we made the discussions, we decided to apply Pfizer BioNTech to the younger population. At what pregnancy stage do you start vaccinating pregnant women? And my second question, it is common knowledge that one of the challenges is in the health system. There are some health providers who might recommend or not recommend pregnant women to be vaccinated. Recommendation of vaccinating pregnant women, and what method did you follow? We'd like to know more about this so we can share this with the colleagues of the region. Well, in our specific case, we did have problems because the Gyn-Ob Association was issuing recommendations, and the press very rapidly asked us, well, are you sure? And so on. So the ministry adapted this, but that was a time in which there was a lot of noise. Pregnant women said, well, I should be vaccinated, and others said, well, the ministry did not say this. And then they asked, well, are you sure I can receive the vaccine? So, well, there was a bit of noise, and the important thing is that we're all on the same track. The way we worked was through a lot of dissemination. We worked with the media, we issued recommendations for the gynecologists, questions and answers that are more focused on the users so that they would better understand the advantages. The ministry also prepared videos. So regardless of those anti-vaccine groups, well, in the case of pregnant women, this was not so easy. In Uruguay, very rapidly, in April, March, and June, we managed to have a large number of pregnant women accept and be vaccinated with this vaccine. But it did give us a bit of trouble initially. Regarding the recommendation, although the ministry said this was universal, we followed the guidelines of the American college. So if there is a chance that a patient has a spontaneous abortion and then this is somehow associated to the vaccination, well, we said, let us start with vaccination after week 12. So this was one of the recommendations we made in order to prevent having any associations with potential abortions and the use of vaccine. The worst moment when we had the 9 or 10 maternal deaths, we said, well, all have to be vaccinated regardless of this is the first 3 months. But now, based on the evidence we have received, we know that there is no risk for women becoming vaccinated, even if they didn't know that they were pregnant. I saw the map of Uruguay that you showed, and it says, well, universal. In March, April, the vaccine became universal for all.
Very interesting. A question for Dr. Paulino. And the vaccination guidelines. What is the gestational age at which it is recommended? I think it's important to know, and also what strategies were used to inform the health staff and providers, because as Dr. Sosa said, this is something that has occurred in many countries in the region, lack of information, the attitude of health providers, and similarly in the private sector. No, take the vaccine after you had the baby. There's a bit of noise there. So I would like to know what has happened in Panama and what are the vaccination guidelines in terms of gestational age that is of interest for our public. Well, first, the gestational age, we didn't exclude any gestational age. When the patient arrives, and this based on the experience, and there's quite a lot of published in the first trimester. Some were vaccinated before and were vaccinated before. There's evidence of that, so we didn't restrict according to gestational age, but there is a population due to prior behavior concepts that prefer to do so in the second trimester. Of course, these anti-vax groups, as I said, are not that strong in the country, but they do work against vaccination to pregnant women and provide misinformation. But there's been great support from the government, from the Ministry of Health, from the Society of Obstetrics and Gynecology, the societies of pediatrics. So I say we have a lot of scientific support in favor of pregnant women, and this has really been useful to reach a high percentage of vaccinated pregnant women. Unfortunately, you can't say the total percentage because this is very changing. So we have a retrospective estimate, but the percentage is extremely high. And we also vaccinate in postpartum. In the worst case scenario, if the woman wasn't vaccinated, when she reaches us, we administer the necessary dose. Indeed, in January, when that was started, where it seemed to be easier to vaccinate postpartum women, well, at present, I repeat, at any gestational age, and we do it in postpartum if we didn't reach the woman during pregnancy. We have over 70% in pregnant women. That is similar to the rest of the population that has 56% 2 doses, 79% 1 dose. The target population, 12 years and over, because we're not vaccinating under that age, it's over 80% with 2 doses. And this may likewise be applied to pregnant women that are target population, where the acceptance level and population vaccinated are very high. So to wrap up, I would like to ask each a key take-home message according to your experience with the COVID-19 vaccination process, starting with Dr. Sosa, then continuing with Dr. Patricia, and ending with Dr. Paulino. Well, the key message based on the Uruguay experiences, try to go in a harmonious way. Scientific societies are important, not only gynecology and obstetrics. We're referring to vaccinating pregnant women. So midwives, obstetricians, gynecologists, and provide the necessary input, particularly to the society and the ministries responsible for having the last word in order to be online. And as we said, we must reach pregnant women. This, of course, regards the people implementing it, to have all the necessary staff, so we don't have contradictory measures. Don't use the vaccine, because the people vaccinating were not aware of the current recommendations. And of course, empowering pregnant women so they request the vaccines. Although we had an agenda, they said, okay, on that day, on such and such a day, it will be open for all pregnant women. So covering all possibilities to try to minimize the number of women that don't access a vaccine. So essentially that tried to concentrate all efforts in the same direction, the executive, the scientific societies, the universities. We must have one same message to go faster and better. Thank you, Dr. Sosa. We truly appreciate your contributions. Dr. Beluba? Scientific evidence is eloquent. Experience in the neighboring countries and the more distant countries speak out loud of the benefits of vaccinating pregnant women. We have to work hard on our communications campaign and be more specific for our target population, the pregnant women and their families, or the workplace where we have pregnant women. And that's a major challenge for us because at present we do have the vaccines. It was hard to obtain them, very difficult really, but to date we have vaccines available, and our greater challenge, and let's hope we can achieve this with house-to-house vaccination and with the communications campaigns we're starting with again, because there's a fear with this new variant. In this way, I think we will reach more women. The evidence is clear. People shouldn't fear it, and the benefits are very eloquent. Likewise, the reduction of maternal mortality is very important when accessing vaccination. That's where we will work, and together with the effort and collaborations from the different organizations. We had support from NGOs for but we also had contributions from the private part and state institutions. I think we have a second E-Day to reach a larger number, so they access a second dose and advance towards a third. Thank you, Dr. Beluba, for your contributions. You've been very generous in sharing the progress and challenges you're facing. That is very important, and this occurs throughout the region. I now want to hand the floor to Dr. Vigil. Thank you for sharing key messages for our audience. Well, first, gynecological obstetricians must regarding the existing knowledge about vaccines. It's only something for obstetricians. Gynecologists have long years of experience with influenza, tetanus, and so on, now COVID-19. We will have more vaccines, I'm sure, so we need to be updated in the necessary knowledge. A gynecologist and obstetrician is the right person to counsel a pregnant woman. So we shouldn't miss that opportunity. Who else will counsel pregnant women? Colleagues have already said it also. The COVID-19 vaccine being used in Latin America are effective and safe. So let's use them. Experience shows that mortality is very high in pregnant women, and experience in my country at least demonstrates that vaccinating pregnant women reduces this significant mortality related to COVID-19 infection. Thank you for inviting me. Thank you. I think the messages have been extremely clear. We are very grateful for your sharing the experience, and I will close the panel saying three basic things. Adding on to gynecological obstetricians, there are health providers, midwives, obstetricians likewise in Uruguay, in Paraguay, in Argentina, Ecuador, Chile, Bolivia, and so on, that are part of the obstetric care team that must likewise be empowered. I didn't mention Peru, sorry, in this message regarding the best available evidence regarding vaccines. Second message, vaccine saves lives, and they have saved the lives of many pregnant women in the countries we've heard today, likewise in others, with very significant evidence we've shared today. And three, the importance of information and strategic communication, not only for pregnant women and their families, but also to work with health providers to ensure we have the best vaccine available. And that's the one that the people receive on day one, as Dr. Fauci said. Ivan Gomez from Plaxonc, the floor is yours to chair the Q&A session. Please don't leave, because I'm sure there are questions from our colleagues. Thank you. Thank you, Vicky. Well, thank you for chairing, and Patricia, Claudia, and Paulina for the excellent contributions, comments, and experiences that help us greatly in the region. Unfortunately, not all countries have had a similar experience. In many countries, maternal mortality due to COVID has been the first cause. The vaccination rate has been low, and your experiences will really help us. Most of the questions we have had already been answered, many regarding gestational age that has been clearly elaborated on. But I would like to know a bit more about your experience regarding COVID vaccine in pregnant women and issues such as those with the triple bacterial vaccine. Are they contraindicated? How long do you wait between one and the other? How do you prioritize them? I'd like to hear about this sort of experience. Maybe Claudio, Paulina, and then Patricia. When we started, we had 2 more vaccines that were being offered because we were entering the winter. One was the anti-influenza that was reaching the country, and we specifically wanted to use it to avoid noise with other respiratory infections. And that's another viral vaccine. But then we had the recommendation between 28 and 38 weeks, the triple bacterial. Reviewing the evidence, well, there aren't that many high-quality studies, but there are many basic studies that allowed us to say if we have viral COVID and influenza, wait 14 days. First, we had a first dose and a second aftermath, so in the middle, we used it, and more specifically the bacterial. Well, there weren't issues because the humoral and antibody processes are different. Anyhow, they were told to wait 7-8 days, particularly if there was no fever. So we tried to prevent interaction. So because it was bacterial, the evidence showed it was possible to vaccinate very close in time. But in general, they took 14 days. That was easier for the health effector. And that was the general recommendation, knowing there wasn't going to be any problem.
Paulino, ¿algún aporte?
Sí, claro. Acá en Panamá, de rutina.
Paulino, yes, in Panama, by routine, we apply influenza vaccine at any trimester of the pregnancy, and then PDAP vaccine. If the patient arrives and is in the 3rd trimester, we apply the 2 vaccines together. This is a public health policy, but now we have COVID-19 and what to do. So as a result of the strategy we apply in the country, these are applied separated by 2 weeks. But we have to know that there is evidence and recommendations that they can be applied together. This is because the 3 vaccines have a different platform. Influenza is an activated virus, PDIP, and the COVID-19 have mRNA. So the 3 are different. So there's no evidence to delay vaccination. If the patient allows, ideally is to wait 15 days between one and the other. In the country, we're applying the 2 together, separated, so we don't separate them at this moment in our country. Patricia, any comment? In Paraguay, we decided to do the same. To wait 2 weeks between applying influenza vaccine and COVID vaccine. But as months went by, the evidence showed that there is no alteration that should restrict this. So we now apply the 2 vaccines together. We apply influenza at any moment of the pregnancy and the other one 20 weeks later. And now the anti-COVID is in the last 2 weeks. So this is this difference. So this is one of the aspects that was a bit confusing. As you are aware, we have participants from all parts of the world. And Amina Taruni from Sierra Leone was asking us about what do we think about vaccinating women in low transmission contacts. Any comments? Well, if you have the option of vaccinating them, it doesn't matter whether the prevalence is low. You know, that should vaccinate them. You should recall that pregnant women are high risk groups. And if they become infected, this will have an impact on their health. And if we vaccinate pregnant women, we are acting on 2 human beings. There is also evidence of the antibodies developing also in the baby through the umbilical cord, and also this will be transmitted during breastfeeding. So if we vaccinate a pregnant woman, possibly, I say possibly because I don't have the definite evidence, we are protecting 2 human beings. Regarding the incidence and or the prevalence, we should also vaccinate pregnant women, even when the prevalence is low. Well, precisely in that sense, there are some comments and questions regarding breastfeeding and vaccination. Any comments or recommendations regarding pregnant women who have been vaccinated and lactating mothers? Well, as Dr. Vigil was saying, if they are breastfeeding and had not received the vaccine, we do vaccinate them. But it is likely that they already received the vaccine prior to childbirth, so they won't be needing the 3rd dose until 6 months later. And it has been demonstrated that they also generate antibodies that are transmitted through the milk. So having been vaccinated or being vaccinated after childbirth is something that we apply. And this is also recommended by the Association of Pediatrics. I'd like to make a comment. Evidence shows that once vaccinated pregnant women, 21 days later, they have antibodies in the umbilical cord. So they, in other words, are transmitted to the baby. So you don't need to prevent a woman from breastfeeding their babies. So it is likely that the babies will be protected too. But also after childbirth, how much longer is are the antibodies detected? Well, there is like a protection effect of the fetus through the antibodies that the baby is receiving. We haven't received any justification to delay breastfeeding, regardless of the moment in which the mother received the vaccine. Patricia? I totally agree with our colleagues. We have to try to vaccinate women right after childbirth if they were not vaccinated before. The only limitation is the availability of vaccines. But if this is available, we do have to proceed. We're almost out of time, and I think we have answered almost all the questions. I would like each one of you to make suggestions regarding the strategies. But I'm very much concerned about some countries where, although there's a high maternal mortality, vaccination levels are still very low. This seems to be different to what is occurring in Panama. So what suggestions would you have in terms of strategies? What would you recommend to the ministries in this regard? The case of Colombia, for example, 350,000 women are pregnant and only very few women have been vaccinated. So I'd like to listen to suggestions from you and any final remarks or comments that you would like to make for the region. So the floor is open to whoever wishes to begin. I will start. Of course, it is important to count on the support of the medical and scientific associations, and of course the support of the ministries of public health is of utmost importance. But we have to go beyond simply just communication and approval. The opinion leaders should also become empowered. Let us take advantage of the social media. The social media are also sort of two-edged blades, but we really have to become opinion leaders. You will realize how many people replicate the messages in a positive way. I see that social media are, for example, Facebook, Instagram, Twitter, you have to send out very clear messages from the opinion leaders, from the medical associations. It doesn't need to be the president, it doesn't have to be the board. Everyone we should all take this seriously. People will start believing us if this becomes massive. Otherwise, the pressure of the anti-vaccine groups, who are very well organized, they use the social media a lot. They are very well organized, but we are not. That is why I urge the organizations and the opinion leaders to really give the social media the value they really have. So they will be really far more effective in this way, even beyond what the ministries can do. Patricia? We now started with the vaccination campaign, going from door to door, and hopefully in that way we'll increase the coverage of vaccinated mothers and pregnant women. The people who surround pregnant women should also have access to vaccine. And we will also strengthen the vaccine campaigns. And like Paulino said, we have to work with the opinion leaders, with those people who are very active in the social media. They should also promote vaccination to those population groups which we have defined in the country. And I think that with that, we can make great progress through communications campaign and also from going from door to door. Thank you, Patricia. Adding on to that, I think any country should define where the problem lies. You referred to the case of Colombia, and why don't they approach the health system? Is it this easily accessible, or what is the reason? Where do we have to focus the work in order to tear down the barrier, whether this has to do with access, with lack of knowledge, and this has to do with how to reach out to these people. In Uruguay, we had that problem at some time. The president's office said, well, we're not going to impose quarantine, but I ask you to do a lockdown. And one of the errors we saw in the group was that we didn't reach the target because some people, some young people, don't really follow this, but through the social media, somehow we should reach out to these specific groups, the specific age groups, for example, through WhatsApp or through Instagram or other social media. This is a way to reach out to young people. So that's one of the areas. We didn't work as a marketing company. We really have to focus on each of the targets in order to say, well, you have to stay at home. Now, that was for the initial stage, but in terms of vaccination, well, we have to see how we can reach out to the different groups. There are different paths that can be followed, as the colleagues mentioned already. Well, yes, this is very important. This shows that this has to do with not only having access to vaccines and having enough vaccines, but we have to work in other fields. Thank you, Paulina, Claudio, Patricia. That was wonderful. And now give the floor to Bremen de Mucio so that he can address us the closing words and the conclusions. Thank you, Pio Ivan. So to wrap up, first of all, let me thank you all who have been here, who have had people from all over the world and who have way beyond the time that had been allocated initially. I'd like to highlight that from all the colleagues who took the floor, I would like to highlight two things. We have even colleagues from Africa who we have had the honor of them joining us. And we saw the enormous inequity in terms of vaccines, even in our own region. In some cases, Panama and Uruguay, and are also speaking about a third dose that was not recommended by the international organizations, and nevertheless, some countries are already applying the booster dose, and other countries have difficulties in accessing even the first dose. That is the world we live in. But beyond that, the comments made by Alba Maria Ropero or Claudio or Patricia or Paulino, and even how you, Pio, and Vicky led the Q&A session. These are very, very useful so that colleagues from other countries and in other scenarios can learn from the best that we heard today. Claudio just now spoke about the responsible freedom, as the president of Uruguay stated. In most of our countries, vaccination is voluntary. That is why we have to have the best knowledge ever to provide the best guidance to women so that together with their families can make the best decisions. And also the healthcare system. Some doctors are totally convinced of the advantages of vaccines, but we should not force women to decide based on our opinions. And we also have the people who are anti-vaccine, and they cannot force women to make the decision not to be vaccinated because this affects their lives. I think this is very simple. I'm quite surprised and worried when our colleagues or the gyne say don't be vaccinated, wait until you finish your pregnancy, you run the risk of your child dying. And this has not been demonstrated. And women who are not vaccinated are those who are dying now and are becoming hospitalized. So don't run the risk for your baby. Your baby might die together with you because you were not vaccinated. And those things are really things that have to be considered. So we have to be responsible.
Para cerrar, quiero agradecerle a todos ustedes que se han quedado hasta ahora, en particular a todos nuestros invitados, también a los
I want to thank all the people who have remained and our speakers and people who have enabled the presentation, Vicky Camacho, Ivan Gomez, and a colleague I had to replace, that's Veronica Reyes from G8 Pego, who is ill, so we hope she gets better soon. And all GTR colleagues that haven't been seen today, but have been supporting all this work. As GTR, we continue working. We know we have much to do. This is our last academic activity together with you, unless something turns up that forces us to share it with you. So happy holidays, all the best for the new year, and thank you for staying on. The recording will be available for those who wish to see it again in YouTube, and all the GTR members participating here and not participating here are open to work together with you and provide support as a multi-agency group working to reduce maternal mortality within the Americas. Thank you. See you soon.
Gracias.
Bye.